Okay. Right. Today I'm going to talk to you guys about uterine factor infertility. So are you able to hear me? Are you guys able to hear me? Can someone unmute and answer? Are you able to hear me? Audible, right? Thank you. Right. Today I'm going to talk to you about uterine factor infertility.
Sandhya ma'am class.
So uterus, so uterus is not just an organ. Please unmute yourself.
Start చేస్తున్నారు ఇప్పుడు.
Guys, mute yourself and go ahead with the class. Right. Uterus is just not an organ. It is a bed for a baby to grow where the life starts. So it is a very, very important organ to be handled, a crucial organ to be handled. It is only possessed by a female where the life starts. Handling the infertility, considering the uterine factor, is very, very important. So today we'll dwell into the. Someone is talking. I'm not able to concentrate. So today we'll dwell into the uterine factors which cause infertility, which affects the fertility, which affects the pregnancy outcomes also. So so going on, we'll just classify. There is no distinct classification. We just classified for comfort and we just classified it for comfortable assessing of the uterus. There is no distinct classification for this. So I classified as uterine factors as congenital factors, which considered where uterine anomalies comes, uterine agenesis comes. Okay, and acquired factors, fibroid, polyp, adenomyosis, adhesions, and infections also comes under acquired factors. And functional issues like implantation issues, recurrent implantation failures, and immunological issues, which is an upcoming branch in infertility, immunological factor of infertility. That's also a reason of uterine factor infertility. So we'll just dwell into the uterine anomalies first. In the congenital uterine anomalies, septate uterus, biconjugate uterus, uniconjugate uterus, and agenesis. Out of all these, septate uterus is the worst anomaly because it actually affects the incidence of infertility is very, very high in septate uterus. So why it is high? Because these few things which should be considered for infertility in the septate uterus. The endometrium compared to the normal uterine wall has reduced number of ostia, glandular ostia, reduction of ciliated to non-ciliated cell ratio is reduced, and the estrogen response on the endometrium, which is there in the septum, is also reduced, and the muscle tissue which is increased. And there is, because of the increased in the muscle tissue, and the discordance in the uterine contractions will happen, and there are defect in the vascular endothelial growth factors. Of all these things, it is a very poor bed for implantation. When the response of estrogen is not good, when the muscle tissue is high, the muscle tissue is why there is a lot of mobility, means lot of peristaltic kind of movements will be there. So the septate uterus, where the septum, if the septum is considered, the implantation is very, very poor. So there is one study which happened in 2014, clinical implication of congenital anomalies and meta-analysis. In that, women with septate uterus, however, the probability of pregnancy was significantly decreased compared to the normal controls. And it is very significantly decreased in the septate uterus. So there is one trial called trust trial. means randomized uterine septum transection trial. So the septal resection is done in quite a good number of patients, but the sample size is less, so the effectivity of the study is also less. This says that even the septal resection also does not improve the pregnancy and live birth rate. But according to so many much of clinical scenarios we have seen, septal resection improves definitely the fertility outcomes in the long run. As I have seen, it improves pregnancy outcomes, but this trial says it doesn't improve. But the trial has a defect that the number of patients were less. 80 patients is not a huge number to take a decision depending upon the trial, but this is a trial which happened. Right, coming to arcuate uterus. Arcuate uterus is a very subtle variant. There's nothing to be done, and they say minimal implantation issues will be there in arcuate uterus. So coming to bicornuate uterus, the good anomaly. Of course, there is one more good anomaly, uterus didelphys. Bicornuate uterus is there, which is a good anomaly. In the bicornuate uterus, usually women does not have difficulty in conceiving. Many patients with 80 to 90% of bicornuate uterus patients will conceive. So, increased risk of mid-trimester pregnancy loss and preterm birth will be there because of the small cavity of the uterus. Oh, the surgical correction is only reserved for patients with the recurrent losses, mid-trimester abortions, and preterm labors. Otherwise, for the conception per se, bicornuate uterus is not a bad uterus. So coming to the IVF part, in bicornuate uterus, single embryo transfer is recommended because the half part of the cavity is only good, and the embryo transfer in the uterine cavity, which is better ultrasound, endometrial appearance and capacity, and easier access. So we have to transfer where the endometrium is good capacity is there, and access is easier. In that cavity only we have to transfer the embryo, and cervical encerclage to be considered after conception because these bicornuate uterus are associated with cervical incompetence many a times, right? So coming to the unicornuate uterus, this is also not a bad uterus. It's also a good uterus. So unicornuate pregnancy complications were high, but the conception is not very poor in unicornuate uterus. The complications of pregnancies were very high: second trimester miscarriages, preterm deliveries, intrauterine IUDs because of the smaller area. The single embryo transfer is highly recommended. You have to do only single embryo transfers in unicorn uterus as far as possible. Right. So on the surgical correction is recommended only if there is any dysmenorrhea, any ectopic pregnancy in the horn, the rudimentary horn, if there is anything rudimentary, then if any dysmenorrhea, ectopic pregnancy, then only surgical correction is needed, otherwise no need of surgical correction. So the next good uterus is the didelphys uterus. It is also uh, not related to any decreased there is no problem of conception in didelphys uterus. Again, it is associated with again preterm labors, small presentations at deliveries. Compared to all other uterine anomalies, this has relatively good prognosis in achieving pregnancy. This and bicornuate uterus. So, next coming to the Mullerian agenesis, MRKH syndrome. The problem with Mullerian agenesis, there is no uterus. So, surrogacy is the only option. But things we have to consider during an OPU, because when we are doing an OPU for this, because these patients have normal ovaries and sometimes PCOS also. So the ovaries are good. So if they are planning for uh, pregnancy, we have to opt for surrogacy. So during retrieval, these patients have lack of vaginal elasticity and surgically reconstruct vaginas. It is difficult to retrieve uterus, and the ovaries are also not properly placed. They are ectopically located. So we have to be very careful in doing an OPU in the MRKH patient. We have to have a preliminary MRI or a proper ultrasound to locate the ovaries to go about the OPU. Right, coming to the acquired factors. So in acquired factors, so the first thing is The most common acquired anomaly we see in the ultrasounds during the OPDs is uterine polyp. So yes, how do we diagnose a polyp? Yeah, we do a saline infusion sonography and we delineate the polyp where it is located, on which wall it is located. We can delineate that. So how does a polyp affect fertility? First thing is mechanical. If it is right at the implantation site, it doesn't allow the embryo to sit there and to grow. And it deviates the anatomy, internal anatomy of the endometrium. That's the first thing. Second thing is the inflammatory factor. Where the polyp is there, the mast cell overactivity will be there. So endometrial NK cells are low, and the leukocyte density is also low, which helps in the adherent implantation to happen. And where the polyp is there, the estrogen receptors are very high and progesterone receptors are low. Wherever the progesterone receptors are low, the bed of implantation is poor. And increased proliferation of cells is there and inhibition of apoptosis is there that also affects the implantation and after implantation the growth of the baby also. The blood supply is also decreased to the baby. So how do you manage a polyp? So endometrial polyps less than 10 mm, if we are not considering any ART, expected management is considered. Many a time spontaneous aggression happens after the
Be careful.
57% of cases. So conversely, if the endometrial polyp is more than 15 mm, are less likely to recur spontaneously. So for that, we have to go about a surgery. So exit. And if the polyp is in the uterotubal junction, means at the cornual area, that if we excise those polyps, definitely the pregnancy rates are improved because it affects, it acts as a mechanical inhibitor for implantation and for the sperm motility also. And for the embryo to come into the uterus also it obstructs. So in all these factors will get corrected. So if the polyp is at the uterotubal junction, if we remove the polyps, the pregnancy rates are improved significantly. So what do we do for polyp? Hysteroscopic polypectomy remains the gold standard for the treatment. So, if the infertile patients polyp, surgical removal is recommended both in natural and ART cycle to have a greater opportunity. If the patient has children, we did not remove it. It will be a spontaneous regression. But if the patient comes with infertility and if there is a polyp, it has to be removed, even if it is a natural cycle or an ART cycle. Because there is a study which says that polyp increases the success. So the next important and actually the most difficult thing to treat in uterine cancer instability, majority of the patients opt for surrogacy is Asherman syndrome. So nowadays we have seen more and more of Asherman syndrome. We don't know why because what's doing abortion and they do curettage after the abortion. The patients with Ashermans are very much high nowadays. So, American Society classified Asherman's as mild, moderate, and severe. The mild disease is few adhesions involving less than one third of the uterine cavity with normal cycles or minimal cycles, hypomenorrhea. Moderate disease is adhesions which are dense, which involves involvement of one third to two third. If it's less than one third, it's mild disease. If it's one third to two third of the cavity, and it hypomenorrhea is there. Severe diseases, patient is having amenorrhea with the dense adhesions. This is very, very, very difficult to treat, and patient lands up in absolute infertility. So, what are the prognosis? The chance of conceiving and delivery after surgery are lower in patients with moderate to severe disease that may improve after surgery if the cavity can be reconstructed and menses recur, but very rarely happens in moderate to severe disease. So, if we do in the recent advancements like PRPs and stem cell therapies have shown some changes, but there are no much studies which says that they improve the endometrium and the basal layer is damaged. Although a normal appearing uterine cavity may be seen after the surgeries, the outcomes, the implantation rates have no much changes. So normal endometrial lining rebuilding after surgery very rarely recurs, may not recur. So usually moderate to severe disease, they'll end up in absolute infertility. Many a times they need surrogacy help. So how do we prevent these assurements? So first thing we can use IUDs, intrauterine contraceptive devices, intrauterine balloons, tanks, and hyaluronic acid and anti-adhesion barriers we can try. So we have restoration of the therapy, restoration therapies like HRTs, sildenafils, and stem cell therapies. I have already told you. So how do we prevent this? How do we prevent assurements? That giving misoprostol like medical MTPs for early pregnancies, not surgical curettage for early abortions. Medical MTPs you tie and curettage in the postpartum or post-abortion period should be avoided as far as possible because many a times only these patients land up in infertility. We have seen so many patients with single child coming with secondary infertility with thick assurements. So when the curettage is done, the basal layer is removed. So there is very difficulty in development of endometrium and uh, adhesions, thick adhesions upon, and we have seen many patients. And there are multiple other reasons for assurance also: severe endometrial tuberculosis, severe endometritis, chronic endometritis which is gone untreated. These are also cause assurance, but iatrogenic assurance is much more in the clinical practice we have seen. So next, coming to the next factor, adenomyosis, which as an infertility consultant we see day in and day out. So what is adenomyosis? So adenomyosis is the ectopic endometrium inside the muscular part of the uterus. This endometrium will move into the muscle region of the endometriosis, which causes the uterus to thicken and the uterine vascularity is affected. So all these things happen. So how does an adenomyotic uterus look in the ultrasound? In a globular, it is like a globe. Like it is not the normal shape of the uterus. It is like round globular. And the main thing is the endomyometrial junction is damaged because this endometrium is moved into the myometrium. The interface is damaged. And subendometrial, I'll show you the pictures of each of these in the coming slides. Subendometrial echogenic linear striations, myometrial anterior and posterior asymmetry. That is a very common thing we see in the scans we do. Anterior wall of the myometrium and the posterior wall of the myometrium are not similar. One is thickened, where the adenomyotic tissue is there, it will be thickened, and the normal one is thick. And intramyometrial cyst, the more very common presentation is intramyometrial cyst. And heterogeneous myometrial ecotexture. So the normal myometrium is damaged and there's lot of heterogeneity happens. See in this picture you can see the heterogeneous myometrial echo, obliteration of junction. There is no junctional proper junctional zone. See, and linear striations. These linear striations are also seen in the uterine wall. And the anterior posterior, see, this wall is thicker, this wall is thinner. Can you see this? So these are all the features of adenomyosis. This is very commonly seen in the ultrasound picture in the adenomyosis. This is hyperechoic linear striations, acoustic shadowing. This is. So how does it affect infertility? So the altered uterine peristaltic activity. So the uterine peristalsis and the direction of the peristaltic activity is altered because of loss of nerve fibers at the endomyometrial junction, interface and absence of nerve fibers in the adenomyosis. And one more thing, endometrial function is affected and receptivity is affected, desitylation is affected, and because of the abnormal concentrations of intrauterine free radicals. Mainly the smooth muscle cells of the uterus with adenomyosis are different from the smooth muscle cells of the normal uterus. So the peristaltic activity is affected, the blood supply is affected. So that is why adenomyosis has a lot of implant. The patient with adenomyosis, when the junctional zone is very thick, there is implantation issues very often. be there. So how do we manage this adenomyosis? There are generous analog we use. There are injectable generous analogs. There are oral nowadays. So these things which help in decreasing the size of the uterus and help in improving the fertility of the patient. Estrogens, progesterones also we use. Danazol, which we usually not use when the patient is for conception, and LNG IUS also helps in decreasing the effect of adenomyosis. Severe adenomyosis, you can try this Mirena. So, how this GnRH in adenomyosis decreases the effect of adenomyosis? It decreases the inflammation. It increases the apoptosis of the adenomyotic cells. It decreases the oxidative stress. It decreases the angiogenesis. So the increased vascular, that proangiogenesis factors and all will be decreased. It decreases TGF beta, so decreases the tumor growth. So overall effect is it decreases the size of the uterus if you give 2-3 cycles of GH and agonist. So, what are the surgical treatments of adenomas? The recent advancements is there is so much of laser ablation done, adenomyomectomies. If it's a localized adenomyoma, we can do a adenomyomectomy. And if it's a diffuse and not laser ablations of small adenomyomas as done, recent advancements is that you can do laser ablation of the adenomyomas, which helped so many patients conceive. So this is a small study which shows that MRI evaluation of junctional zone thickness is the best negative predictor factor of implantation failure. So this study says that pregnancy rates are 45% if less than 10 mm means junctional zone thickness, the endomyometrial junction thickness. It's not endometrium, it's endomyometrial junctional zone thickness. If it's less than 10 mm, it's 45%. If it's 10 to 12, it's 16%. If it's more than 12, it's 5%. So if it's more than 12, its implantation failures will be higher. So next coming to the fibroid uterus. So how fibroid affects infertility? This everyone knows. Subserosal fibroids, no obvious fertility issues. Submucous fibroids, yes, poorer reproductive outcomes will be there. In that intramural myomas may have poorer reproductive. There are multiple intramural myomas. Uh, if the intramural myomas are multiple, or if the size of the myoma is very high, if it's more than 5 centimeters myoma, even though it's an intramural myoma, it affects the peristaltic movement of the uterus. So it affects implantation. If it's more than 5, you have to remove that. You have to do a myomectomy and then do a transfer. And if it is very closer to the implantation, you definitely have to remove it. If there are multiple myomas, you have to remove because it affects the peristalsis. So next, coming to the functional factors of infertility, the immunological factors, which is very much hot topic nowadays. Immunological factor of infertility is dealt in very different ways. There are so many therapies which have come out for this immunological factor of infertility. I don't go into the depths of it. I'll just tell you the NK cells, the uterine NK cells, and the peripheral NK cells. The NK cells are a part of immune system. We know that there are in the peripheral bed and in the endometrium. So peripheral NK cells are phenotypically and functionally different from the uterine NK cells. So the peripheral NK cells are the CD56 dim cells, they say, have the grading of it. And 80% of uterine NK cells are CD56 bright cells. So peripheral NK cells have significant cytotoxic activity, while uterine NK cells have little cytotoxic activity. And they're rich source of cytokines, particularly angiogenic ones, which possible roles in regulation of trophoblastic invasion. So basically, if the NK cell activity, there are more too few NK cells and too many NK cells, and their impaired function have shown in reproductive problems like recurrent miscarriage and implantation failure. So the newer therapies of lymphocyte infusion therapy (LIT) have come up to balance this NK cell activity. So that is a very deep and different topic. I'm just touching it to make you understand that that is also a part of uterine factor infertility. Right. Now coming to the cervical factor, that is cervix is also part of uterus. This is gone untouched, but many a times is also part of infertility. So the anatomical alteration of cervix abnormal position of cervix pointing upwards, and the hypoplastic cervix, which usually denotes a hypoplastic uterus also many times. This hypertrophic cervix, because of older lacerations, chronic cervicitis, also affects the deposition and retention of the sperm. And the stenosis of os, cervical canal stenosis, which is a sequelae of electrocautery, cryotherapy, conization, any amputation of cervix may affect the sperm migration. So these are the cervical factor infertility also should be in mind. That is why a perspective examination, a provisional examination for an infertile couple is very, very important to understand the basics of it. So how do you treat this? Stenosis, yes, dilatation of cervix under anesthesia. It's a hypoplasia of cervix. We have to investigate and you have to give sometimes HRT improves. If there is a growth, we have to excise it. There is a stenosis managed by gentle dilatation, preventing the damage to internal os by overdilatation. So very gently dilate the cervix. If you overdilate it, it may result in incompetent as again you have to go for a circlage. So very with the cervical stenosis, preferably under anesthesia, try to dilate it and see. If there is an infection, just do a culture sensitivity. If there are synechiae, DNC may be tried, but forceful dilatation of cervix should be avoided. Right? Uterus is not just an organ of reproduction but a cradle of creation where life begins its very first chapter. So, handling of uterus for an infertility consultant is like a baby because that baby holds a baby. So, we have to take care of it. So, we have to very carefully handle uterus and monitor the lining and prevent infections for uterus, prevent any damage to the uterus for a for a embryo to be implanted and grown in that uterus. So this is it. So any questions you can ask me? So any of you can any questions you can ask me and yeah.